this month has been a nightmare, frankly, for the nurses across the nation. And we said it because the concerns that were coming in were so significant and so consistent that we thought we needed a venue where we actually had the nurses talk to each other so they could hear each other's voices. I think and they're looking for answers. And we've been attempting to try to get hospitals in this country to actually hear the nurses, hear the concerns. We've been told a lot of things that have been wrong. We've been lied to in terms of the preparation in the hospitals, and we know this because the nurses are telling us this. And the nurses are the ones who are caring for the patients. This was completely validated yesterday when the nurses from Dallas called us and talked to us from the heart. And some of the most compelling, horrendous stories that Deborah Berger will be reflecting here about what actually happened in Dallas. But what happened in Dallas could happen anywhere. And that's precisely the point. So we've been essentially ignored by the White House and by the CDC. And they've been giving the hospital far too much credit in terms of assuming that they would actually take their advice. And what we've come to is that we have to take pretty dramatic action for nurses across the country. You know, we've threatened the hospitals. We've said that we would do all the things that we need to do. The nurses who are in union hospitals across the country, we have bargaining demands. Those will escalate into, possibly pickets with the public to demand safety standards in the hospitals. But for the rest of the nurses in the nation, we've been deeply concerned, and we've been grappling with what to do and what can we do and how can we help. And we realize this is outrageous, that this is our responsibility. This is the responsibility of our elected officials to actually protect this nation and to protect the first line of defense. So what we've done is to draft a letter to the president, and we sent it. And we're sending it to the governors of the state and to the congressional caucus. We're sending it to Congress, we're sending it to the president, we're sending it to the governors, and we'll send it to anyone who will listen. And we're asking the president of the United States to invoke his executive authority to protect the nurses and other healthcare workers in the country. And we'll read the letter. The letter's today, October 15th, 2014. On behalf of registered nurses and other healthcare workers across the United States, we understand that the only way to adequately confront the Ebola crisis that the World Health Organization has termed the most significant healthcare crisis in modern history is for the President to invoke his executive authority to mandate uniform national standards and protocols that all hospitals must follow to provide safety for our patients, healthcare workers, and the public. Every healthcare employer must be directed to the following precautionary principle and institute the following: optimal personal protective equipment, and we go on, full hazmat suits, and we give the specification in line with the University of Nebraska Medical Center, that there shall be 2 direct care registered nurses caring for each Ebola patient, with additional registered nurses assigned as needed, based upon the registered nurse's professional judgment. This letter will be available on our website, and we'll hand it to the press. That there will be continuous interactive training for nurses and we go on with more technical language around that. We want each employer to adhere to the standards that meet or exceed the University of Nebraska Medical Center, or a higher standard if it's in use. The Ebola pandemic and the exposure of healthcare workers to the virus represents a clear and present danger to public health. What we've heard this morning, obviously, is that another nurse has contracted the Ebola virus. We're expecting the situation to be worse. We know that without these mandates to healthcare facilities, we're putting registered nurses, physicians, and other healthcare workers at extreme risk. They are first line of defense. We would not send soldiers to the battlefield without armor and weapons. In conclusion, not one more nurse, not one more patient or healthcare worker should be put at risk due to the lack of healthcare facility preparedness. The United States should be setting the example on how to contain and eradicate the Ebola virus. Nothing short of your mandate to the President, the optimal safety standards apply, will be acceptable to the nurses of this nation. And we sent that to the United States of America's President today. On this call, we have representatives from across the world. We have nurses who are in the organizations that were exposed to the Ebola virus and contracted the Ebola virus. We have statements from the nurses in Liberia. We have a nurse, a registered nurse on the phone from Spain who will be speaking to us. And we have nurses from other countries where the insecurity is rampant. Now, I will say this, and we've maintained this. The nurses are not fear-mongering. What they're attempting to do is to actually have containment, have the highest standards, to be able to care for patients and care for themselves, to basically eradicate fear and to eradicate this disease. But without action at a very high level, the nurses, how can we expect the nurses to do this on their own? The employers, as we heard from the nurses yesterday in Dallas, were told, it's up to you. Well, they don't control the resources of the hospital, do they? I mean, if the nurses controlled the resources, there wouldn't have been an Ebola crisis in this country, no doubt, because we would have had preparedness when the CDC requested that early. So we're going to hear from nurses across this country. We've told the press continuously that the nurses are saying the same things across the country. We've asked for a cross-section of nurses from across the country and across the world to speak to this. And the way we know this is we very quickly, a month ago, did a few weeks ago, or I can't even remember, like this was just going so fast, a survey to find out what the nurses were saying. And Zinni Cortez, who's a vice president of the National Nurses United, is going to read us the results of that survey, and then we'll go to the Liberian healthcare workers' statement. Zinni?
As of today, October 15, we have obtained 2,350 responses. Registered nurses from 820 hospitals in 47 states, including the District of Columbia. Our nurses say that 85% of their hospitals have not provided education on Ebola, with the ability for the nurses to interact and ask questions. A percentage of that remains largely unchanged. According to the World Health Organization latest numbers, confirmed or suspected cases of Ebola is 8,914. Confirmed deaths, 4,447. Projections by the week of December 2014, the first week of December 2014, there will be 10,000 cases of Ebola in the nation across the world. Official contact counts related to the death of Mr. Thomas Duncan, the patient in Texas, that's the first patient infected by Ebola in the country. Before he was hospitalized, he had exposed or potentially exposed 48 people. Once he was hospitalized, there were at least 76 more people who were exposed.
Thank you, Zinni. Jean Ross, the co-president, is on the line, and she's going to be reading us the statement from the Liberian healthcare workers. Jean, operator, can you unmute for Jean Ross, please?
Am I on?
Yes.
Okay. This is dated October 15, 2014. Statement by Darnell. I'm getting that. Can you hear me?
Yes.
Okay. Statement by Garlo Williams, General Secretary, Liberian National Private Sector Health Workers Union. Since the outbreak of the Ebola virus in March this year, more than 2,316 of our citizens have died, including 95 health workers, and more health workers are expected to die due to the lack of protective suits fighting the Ebola virus. The Ebola virus has penetrated 8 of the 15 counties in Liberia and is impacting many of our neighboring West African countries as well. We experienced some 14 years of civil war and crisis in Liberia that caused a serious brain drain in our health sector. Ebola is now threatening the lives of the few health workers we do have, along with all of our citizens. The long-term impact on our health system will be devastating. The situation here in Liberia is dire, and our members, the nurses and other health workers who are on the front lines of this crisis, have bitterly protested the fact that the appropriate, proper protective equipment has not been provided to us. Workers have gone on strike to protest this lack of protective gear and the lack of hazard pay. It is because we have not been provided these protective suits that so many of our members have died from the disease. Liberian nurses and other health workers want to take care of our patients, but we don't believe that we should be subjected to a death sentence for doing so. To deal with this crisis, it is imperative that the doctors, nurses, and other healthcare workers be provided full protective equipment so we don't contract the disease ourselves and are thus able to continue to care for our patients. This is why we are so grateful to National Nurses United in the United States for donating hazmat suits to help fight Ebola in Liberia, and to Global Nurses United for providing support for our union. This kind of international solidarity is exactly what we need, and we would, of course, encourage others to make similar donations. We look forward to working with these partners for the complete eradication of Ebola in Liberia and elsewhere in West Africa. We also want to express our sympathy for the Liberian patient who died in Dallas and for the registered nurses in that hospital who took care of him and now have contracted the virus themselves. We applaud the stance taken by National Nurses United, calling for hazmat suits for all frontline caregivers and training and drilling for nurses and other caregivers in the United States. We have to remember that the crisis here in Liberia started with a few patients contracting Ebola, and it spread from there. The world needs to address the underfunding of public health infrastructure around the globe to deal with pandemics such as this one.
And with the nurses in that country, and are very, very sad about what's happened to them and what's continuing to happen to them, and it's not acceptable. The National Nurses United did send them 1,000 hazmat suits because they didn't feel safe to take care of their patients. Regrettably, we didn't know that our hospitals wouldn't be providing those to the nurses here at the time as well. And so this should happen today. Our hospitals are extremely wealthy. We've also, from we belong to the Global Nurses United organization with nurses across the world, and we've contributed a generator to help them, as well as a laptop computer this week. And so now we're waiting for the nurse from Spain to come onto the phone. So I was trying to take this in order in terms of how it's happened on different continents, but I will ask Deborah Berger to now talk a little bit about what happened, what we found out yesterday in terms of, we had a press conference yesterday, so we've already discussed this with some of you, but just to hit on some of the points about what's happening in Dallas and what we know about Dallas. And we will take questions from the press later on this as well.
So I'm Deborah Berger, president of National Nurses United, and what we heard from the nurses yesterday was truly heartbreaking and outrageous and totally preventable. And we want to make sure that this does not ever happen again. I will read some of the instances that indicate how ill-prepared our employers are in this country. First, Mr. Duncan was left for several hours, not in isolation, in an area where other patients are present. Lab specimens from Mr. Duncan were sent through the hospital tube system, and instead of being specifically sealed and hand-delivered to the lab. The result is that the entire tube system, which all lab specimens are sent, was potentially contaminated. Initial nurses who interacted with Mr. Duncan wore generic gowns used in contact droplet isolation, 3 pairs of gloves with no taping around the wrists, surgical masks with the option of an N95 mask and shield. And some supervisors said that even the N95 mask was unnecessary for 3 days while providing care. The gowns that they were finally given still exposed their necks, the parts closest to their face and mouth. It also left exposed a majority of their heads and their scrubs from the knees down. Initially, they were not even given surgical booties. They were told to use medical tape and had to use 4 to 5 pieces of medical tape wrapped around their necks, and the tape was not impermeable and it had permeable seams. Nurses had to interact with Mr. Duncan with whatever protective equipment was available at the time, when he had copious amounts of projectile vomiting, diarrhea, and other bodily fluids coming from his body. Hospital officials allowed nurses who interacted with Mr. Duncan to then continue normal patient care duties while taking care of other patients, even though they had not the proper equipment to personal protection equipment while providing care for Mr. Duncan. Nurses who may have been exposed were one day kept, patients who were one day exposed to the Ebola virus were one day kept in strict isolation units. The next day they were ordered to be transferred out of strict isolation into areas where other patients, even those with low-grade fevers who could potentially be contagious. The nurses said, were protocols breached? The nurses say there were no protocols. There was no mandate for nurses to attend training. There was no advanced hands-on training on the use of personal protective equipment. Even when trainings did occur, after Mr. Duncan had tested positive for Ebola, they were very limited and did not include having the nurse in training practicing the proper way to don and doff the appropriate personal protective equipment. Guidelines had been changed several times, and nurses, in summary, the nurses state that they have been given no policies or regulations regarding cleaning and bleaching of the premises, and without access to housekeeping service. There was no one to pick up hazardous waste as it piled to the ceiling. They did not have access to proper supplies, and observing the infection control did observe the infection control department and the CDC themselves violate basic principles of infection control, including cross-contaminating between patients. In the end, the nurses strongly feel unsupported, unprepared, lied to, and deserted to handle the situation on their own. Thank you.
I believe that reflects the nurses across the United States, not the world. Not only that, we're having some problems in terms of bringing the nurse in from Spain, so we'll ask Martha Kuhl, the NNU treasurer, to read her statement. And this will be the final statement.
This is from nurses in Spain. In Spain, we are deeply saddened by the news of a U.S. nurse being infected with Ebola while treating the first U.S. patient that has now passed away from this disease. We are hoping for her quick recovery and for this to be the last case of Ebola that you have to treat. For this reason, we think it is fundamental to open the lines of communication with all organizations of nursing professionals so that we may share experiences, plans of action, and prevent further infections, not only in our countries, but also in West Africa, because we all count on nurses working in those regions. As the first country to have an infection outside of the current epidemic region, we understand the concern and worry of those citizens and the principal role you play as National Nurses United. The campaign we are currently working on is similar to the one we are working on here in Spain. In our country, it is evident that there is a lack of proper protocol, insufficient training and practice for our nurses and other healthcare workers. The information received by our staff has been insufficient, and the training on individual protection gear has not been rigorous enough. In some centers, they didn't even have the materials needed to care for potentially contagious patients. Since the beginning beginning of the crisis in Spain, the Nurses Union has demanded from the authorities on sanitation that all personnel that works in the hospital should have experts with them on this subject, similar to what the Army has in terms of teams of experts that are formed when there is biological risk. The same as organizations that are nonprofit that are dealing and have been dealing with this type of illness for years. Forming personnel to do this work since it's been years now, trying to eradicate this disease in countries as where this new epidemic has started.
Thank you. Okay, we're going to open up the lines to some of the nurses across the country to talk briefly about what's happening in their hospitals. And I'll start with Lori Hoagland in Oregon. Lori, can you open up the lines for Lori Hogan, please?
Yes, this is Lori Hoagland. I'm a nurse practitioner, and I've worked for over 30 years in clinics. And I'm deeply concerned that if we don't provide the proper tools immediately and the proper protocols, that this disease, with the rapid movement of people across this country, will spread. And when people come in with fevers and diarrhea to clinics, there will be no way to tell whether it's Ebola or the flu.
Just a second back so far. I've gotten Donna.
And, you know, having worked with RN Response Network in Port Limon, Costa Rica, I've experienced many people waiting in long lines, looking for help, running out of resources very quickly. And so we need to be very proactive and move quickly to contain this virus. It is a deadly enemy that's come to our country and penetrated into our country. Thank you.
Texas to Yadira Cabrera. If you could open the line for Yadira Cabrera, please.
Yes, this is Yadira Cabrera from El Paso, Texas. And basically what I want to state on this call is that hospitals may say they are ready, but my experience is that they are not. Contrary to what many hospital administrators say about preparedness, nurses at my hospital are reporting a very different story. What we've seen, for example, is we have received a training of approximately 10 minutes regarding Ebola, and not given an interactive type of training, which is what we demand. So we believe that these hospitals must go beyond business as usual and prepare accordingly at the optimal and highest standards. Preparation is not handing out a color printed flyer or sending staff email with links to the CDC website, for example. Preparation is not announcing that you'll do training in 4 or 6 weeks. Preparation is not waiting until the patient arrives in the hospital with Ebola-like symptoms. We, as expert registered nurses, and we have to get educated, trained, and perhaps have some sort of drill with the whole team from the point of triage to treatment all the way to waste disposal.
Donna Kelly Williams in Massachusetts. Okay, I think we're having a problem. I know she's there somewhere. Let's go to Sue Cannon in California. We have a room full of nurses from California, by the way, in front of us, so I'm sure all of them have the same story. But Sue Cannon, operator, can you open the line for Sue Cannon, please?
Yes, hello. Hello.
Hi, Sue.
I am Sue Cannon. I've been a nurse since 1997, and in 2005, I went with the RN Response Network to help take care of people who were affected by Hurricane Katrina. 2 days after the hurricane hit, it was declared, the affected areas were declared a public health emergency. And so many New Orleans residents were without the basics, food, water, medical help for days. Floodwaters that people had to wade through were contaminated not only with sewage, but petroleum and other toxic products. One hospital in the city, you probably remember, Memorial, was stranded with about 2,000 patients and workers who were desperately struggling to survive and get rescued. The needs of these people under the microscope that Hurricane Katrina offered showed classic public health issues: sanitation, hygiene, infection control, clean and safe water, access to medical care. All of these things were problems. In America, we watched on our televisions in horror as we saw the failure of our public health system and the failure of our for-profit hospitals, completely unable to handle these needs. It could help. Things did get gradually better, but, Ebola is here. We don't need to reinvent the wheel. There are protocols already in place. Hospitals just need to give us protection that we need and keep us safe and keep us contained. Thank you.
Thanks a lot. Those who've spoken, if you could put your phones on mute because we may come back to you. Okay, I want to go to New York at this point in time. Anthony Chapa.
Good afternoon.
Hi, Anthony. So tell us what's going on in New York and your concerns, please.
Sure. I'm Anthony Ciampa, registered nurse at New York Presbyterian Hospital in Manhattan, and member of the board of the New York State Nurses Association. So first, the good news. Our public hospitals, in particular the main facility in Manhattan, Bellevue Hospital, has a high level of preparation with protocols in place and round-the-clock training and drills. Bellevue is the go-to hospital for Ebola patients should and when they arrive. Unfortunately, most hospitals are not prepared here. At my hospital, New York Presbyterian, the largest private facility in New York City, preparation, I am sorry to report, is inadequate. We are using generic gowns and gear and not hazmat suits. Here's a short sample of what the nurses are telling me. 1. RNs were provided a 2-page leaflet on how to put on PPE and had one person demonstrate the proper way to put them on. The in-service was short and a few minutes long. The PPE is not one size fits all, but appropriate sizes are not offered. The PPE impervious blue gowns are similar to the blue gowns on the floor, and things can seep into them. The masks and face shields are not sealed and protective as they need to be. 2. On another unit, nurses report concerns about our Ebola mock code. We weren't actually trained on using PPE, so they were reading the instructions as the nurses put them on. Also, they didn't have all the sizes available. Expectations are not clear when it comes to protocol and Ebola patient care. Frontline nurses are not invited to be part of the decision-making process. The other concern was that they made the simulated patient vomit and bleed out, and the nurse was instructed to clean this up first before housekeeping will go near it. Yet that same nurse is expected to touch other patients, put in IVs, etc. We, the New York State Nurses Association, had put in an information request to New York Presbyterian on October 8th, based on the University of Nebraska model. And after a week of non-response from them, we learned today that the employer is making improved changes, but we have yet to see acceptable standards of care. So that's my report from New York. Thank you.
Thank you, Anthony. You're also a member of the NNU, and we appreciate that. Donna Fleming-Kobe from Washington, D.C., please. Could you open the line?
Yes. Good evening, everyone. I'd like to report that I work at Providence Hospital in D.C. We were given some brief in-service with some isolation cards that had the basic generic gear to wear. We don't have the hazmat suits, and I was notified that the unit in which I worked on, that's going to be one of the designated units for Ebola patients, and that unit is not equipped to handle Ebola patients there. The room that is designated for this patient is a small room. We use that room for TB patients. It's supposed to be a negative flow room. I don't believe it works. The room works. There's normally when the alarm is set and the door is open, the room is supposed to alarm when the doors open, but it does not do that. And the nurses are afraid. You know, the room that's designated is right up at the front desk. And it's just an accident waiting to happen. A major problem is that we do not have a national integrated healthcare system. We have multiple corporate hospital chains, each responding to Ebola in their own way or not responding. What is needed is a uniform, coordinated national standard. The focus is Ebola today, but as in the past, inadequate responses to H1N1 have shown we need readiness for all pandemics, as more are surely coming. Also, during the in-service, we were told that we don't have goggles. They said that they couldn't afford the goggles. So it's a mess. We need help. The nurses that are there, and we are the first person. We're triaging the patients. The doctor's not triaging us. The nurses triage the patients. They come into the waiting area in the emergency room. They sign in. They sit down. We have 3 closed units in our hospital. Why can't they designate one of those units as an isolation unit? We have no way to decontaminate ourselves. It's sad. Thank you.
Thank you. If I were writing the papers, that would be my headline, "We need help." Because that's certainly what we're hearing. Go to John Armeligus in Michigan. Get open the line for John Armeligus. John, are you there?
Thank you, Roseanne. What we are seeing here in this region of the country is similar.
I've been listening in.
They say that they're ready, but my experience is that they're not. Contrary to what many administrators are saying about preparedness, nurses in this region are telling us a different story. In part, we've heard that hospitals are placating cheap materials such as cheap gloves. The nurses have asked for higher quality gloves, for example, that are impermeable. Nurses have reported they have not gotten instruction if they are going to care for these patients in regards to how to safely dispose of contaminated materials. There are no hazmat suits that we have heard. The nurses are being told that the gowns are what they are to use, and those gowns are in and of themselves not adequate. They're too short. The shoe and footing coverings are also not impermeable. We've heard from nurses at a hospital where they set up a negative pressure room in the ED, but there's no ante-room for the other nurse to observe the care that the direct patient care provider, that nurse, is providing to the Ebola patient. Further, in regards to this specific example, the room of this negative pressure ED room is left open, and it's not even ready for use. So that's some of the observations we're hearing in the Midwest. Thank you.
I'm sorry to hear that. Donna Kelly Williams in Massachusetts, are you on?
I am.
Okay.
I'm on with the Thank you. I can absolutely say that everything that we've heard is exactly what's happening here as well. But I'll just cut to the chase. But most outrageous in Massachusetts is tomorrow they are convening a public forum by the Public Health Commission for a public hearing on the Ebola preparedness in the Commonwealth of Massachusetts. The invitations to this have gone out to the high-level executives of the hospital and not to nurses on the front line. We have asked to be able to testify on what we're seeing on the front lines and have been denied the opportunity to testify. about the preparedness that we're seeing as frontline nurses. So the nurses in Massachusetts are prepared to go to the State House tomorrow to be available to not only testify, but also to be able to update the press on what we're seeing inside the hospital. Thank you.
Thank you. Thanks, Donna. That's outrageous. We will be holding conferences across the country where nurses and talking to the communities. We're going to we'll keep our own forums. If we're not invited, if the nurses who are doing the work are not invited to be at the table that affects their lives, that's a national disgrace.
We agree 100%.
Donna. Okay, let's go to Illinois, to Talasa Hardin. Talisa?
Yes.
Are you on? Okay.
Yes. So what I've been hearing is similar to what we're experiencing here in Chicago. I work at the University of Chicago in the burn unit. It's a unit that's never get me. So it may be the first place for the patient. Raise our concerns to the hospital. They need to take me down the ER where they're currently preparing nurses patients. That was a week ago, and nothing has changed. The isolation is just a mistake, or they couldn't need. For the work that they're doing with the ER nurses, that it needs to be widespread throughout the hospital to where any patient can come into contact with other patients and nurses. We know that this country has the ability to safely take care of these patients, and that and what we really need is for the hospitals to actually demonstrate that they have the will to do this. We're the frontline caregivers, and we'll take care of these patients, but we just have to fight and make sure that we can do it properly. Thank you.
Back for comment from the University of Chicago. Thank you. All right, the last speaker is Karen Wildberger from Florida. Karen, are you on the phone?
Yes, I am.
Thank you, Karen.
I'm Karen. I'm Karen. I'm from Florida. The hospital I work at, the nurses have had no training or education whatsoever as far as the Ebola. We have one nurse who happens to be a nurse rep, and she spoke up, and she was trying to get some education, actually from the respiratory therapist who brought bunny suits and all up to them. When she got home that night, she was...
This is Lisa Bresso.
Hold on. Janet?
Hello, this is Lisa Bresso. I'm supposed to be speaking to this group soon.
Yeah, I'm Rosa from Nurses United of Spain. Hello?
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 To Spain.
Can you hear me?
Yeah, on you short. Nikki, you want to get control of this? All right. We're going to bring you back in.
Sorry, I don't hear you. Hello?
Should I continue?
Spain, please stand by.
This is Karen again from Florida. So our nurse, when she got home that evening, she called the CDC to try to get some education in regards to Ebola and how to care for her patient and all. She received a call later that evening from her charge nurse and then spoke to the nursing supervisor, where she was taken off the schedule for the next day. About 20 minutes or so after that, she received a call from her director where she was suspended indefinitely and pending investigation. She asked why, and they said that she violated HIPAA because she called the CDC to get education for her and her fellow nurses. And as the union, we are fighting for her to get her to be able to be reinstated back to work with back pay. and we still have yet to hear anything from management, and they are kind of avoiding us. That's it.
Thank you, Karen. That's disgusting, obviously. The nurses all in this room gasped when you said that. It's difficult because we have 4 different lines coming in here, one internationally, one with the press, 11,500 nurses, and then other professionals. So I think given that, we're doing a pretty good job. So I'm going to turn now to brief presentations with asking Bonnie Castillo, who heads up our Registered Response Network, to conduct the next portion of this, and then we'll go to questions.
Sure. Thank you, Roseanne. I'm Bonnie Castillo, and I'm the Registered Nurse Response Network Director. And I just have to say briefly before I introduce the other speakers that generic isolation cards that have droplet precaution, protection, and ill-fitting suits is not protection. It's not preparedness. And in fact, it's setting us up for infection, which is completely unacceptable, and that's why we're here today. So, from the front lines of West Africa, the first presenter, I'm hoping that she's on the line, Rebecca Milner. She's the Vice President of the Institutional Advancement International Medical Corps on international. She works on international relief efforts in West Africa. Rebecca, are you on the line?
I am.
Great.
So I want to open by thanking National Nurses United and the Registered Nurses Response Network for its early support of our efforts to respond to the Ebola outbreak. In fact, NNU and the network were one of the first calls that we received when we announced that we were responding. So I just want to thank you for reaching out to us for that. Just a little bit of background about International Medical Corps. We're a first responder to war, natural disaster, famine, and disease. And we've responded to some of the biggest crises of the last 30 years, including, the Haiti earthquake or the crisis in Syria right now, and the conflict there, and then in West Africa against Ebola. The thing that makes International Medical Corps a little different from other humanitarian groups is our focus on training. And we give doctors and nurses the knowledge and skills that they need to take care of their own people over the long term, with the goal of restoring self-reliance in these really difficult environments. We've been around for 30 years. We've delivered more than $1.8 billion in healthcare and training to tens of millions of people in 70 countries. And today we have about 5,300 staff around the world, and 96% of them are local to the communities in which we work. The Ebola crisis is an unprecedented emergency for us and the international community in general. The swiftness of the outbreak and its shockingly high death rate, which is now, by some estimates, exceeding 70%, has taken the global community by surprise. This outbreak is also the first time that Ebola has been transmitted in an urban environment, and so the spread has been very fast. International Medical Corps deployed its emergency response teams to Liberia and Sierra Leone this summer in July, and it became very clear very quickly that we needed to get involved in treating Ebola patients. There simply just aren't enough health professionals on the ground in Liberia and Sierra Leone to deal with this outbreak, and the health systems that exist there were weak before the outbreak and have completely broken down since Ebola has taken over. Just a few quick highlights. The World Health Organization concludes that conditions in Liberia, Sierra Leone, and Guinea continue to deteriorate. The number of cases in both Liberia and Sierra Leone are increasing week over week, and there is no evidence at this time that the epidemic in West Africa is being brought under control. The World Health Organization estimates that there is a need for 2,900 beds in Sierra Leone and Liberia, and the existing bed capacity right now is only 820. We have opened up an Ebola treatment unit in Bong County, Liberia, which is a 4-hour drive north of Monrovia in the epicenter of the outbreak. And we began accepting suspected Ebola cases on September 15th. And our Ebola treatment unit is a sort of semi-permanent building. It's based on the World Health Organization's and Médecins Sans Frontières layout and standards. It includes all of the things that you would think would be needed: dressing rooms, treatment facilities, isolation wards, morgue, and a burial site. And this is just an exclusive facility to treat suspected Ebola cases. We also run an ambulance service to safely and efficiently transport Ebola cases. As of yesterday, our ETU had admitted 91 patients in the last month. And moving forward, we're going to open another Ebola treatment unit in a 50-bed Ebola treatment unit in Lunsar in Sierra Leone at the end of October. And we are exploring opening up 2 additional ones both in Liberia and Sierra Leone. And in addition to providing the direct treatment, we're also working on training up other health professionals on the ground so that they can provide treatment and run Ebola treatment units, and which means that we're mobilizing clinicians, logisticians, water sanitation, hygiene professionals from around the world and also locally to help staff up and treat and run these facilities. The 70-bed facility in Bong County, to run it 24/7, 24 hours a day, 7 days a week, requires a staff of 200 people. And that's not only frontline healthcare workers like nurses, but also people that are involved in infection control, as well as burial teams. Some of the challenges that we see is really around training, right? Unlike routine primary health care, everything has to be done right with Ebola surveillance and treatment. If not, health workers, as everyone well knows, and we've been talking about this for the past hour, health workers are vulnerable and can be infected. In Liberia, Ebola is called nurse killer because so many Liberian nurses have died while treating Ebola victims. And it's really important that we start training people immediately, and it's all of the things that you've been talking about, helping them begin to know how to put on the personal protective gear, what to do when treating patients, and then how to take off the personal protective gear, because that's a very vulnerable time for health workers, and then what you do with all of the waste. Right now in our ETU, we're burning everything. Incineration is going on 24/7. Need more labs, of course, and so that we can quickly determine if patients are positive or negative for Ebola. And then, as you all are struggling with in your hospitals, supplies are very difficult for us. The personal protective gear and equipment that we need, including generators, fuel, clean water, all of those things, are really difficult to obtain, and we're experiencing shortages, and that's an issue for us on the ground. Do want to, again, repeat my thanks for your donation of the personal protective equipment that you made to the Liberian nurses. It's really, we anticipate that for the facilities that we are running, that we'll need 25,000 PPEs per month to run the facilities. These are a few of the immediate challenges, and it sounds very hopeless, but I don't think it is. We do have a window of time to bring this outbreak under control, and as a global community, we can. We simply need to devote the resources and the manpower to stop it. Thank you.
Rebecca, and Rebecca is giving the live report from West Africa, and unfortunately I think statistically we're not doing much better here in terms of the number of cases, and we should not be having this, incurring the same kinds of challenges that they're facing in West Africa. We know that we can do better, and our next speaker is Dr. Lisa Brassel, who's professor in the School of Public Health, Division of Environmental and Occupational Health Services at the University of Illinois. Dr. Brassel, are you there?
I am here.
Thank you.
Me? Yes. Okay. Thank you. I appreciate the invitation to speak to the group, and
Some of you may be familiar with a commentary that I wrote and that was published. I wrote with Dr. Rachel Jones, who's a colleague of mine, and was published on the Center for Infectious Disease Research and Policy website at the University of Minnesota in the middle of September. We wrote that commentary because we were asked to consider whether Ebola was an aerosol transmissible disease. And I have to admit, at the time I was asked to consider that, I was somewhat skeptical. But as I looked at the data and read through the literature and began to examine what we do know, what little we do know about Ebola, it became more clear to me that aerosol transmission was a strong possibility. So from what we know about Ebola, the modes of transmission are really not known. What we do know is that there are risk factors based on post-outbreak assessments and epidemiology where, we're living close to someone, living in the same house as someone, working closely with them as a healthcare worker, caring for someone, especially toward the more severe symptom phase, and encountering an Ebola body during a funeral. All of those are risk factors, but those risk factors don't really tell you clearly whether it's direct contact with body fluids or it's aerosol transmission or what exactly is the mode of transmission. And as far as I could tell, there are no human studies that elucidate that. There is a strong paradigm in the infection control world that direct contact is the only explanation for most infectious disease. And for many years, I've been a proponent of the perspective that we should be more careful about ruling out aerosol transmission if we don't have very good data. So what I started to examine with the data in my commentary was what sorts of information is there about aerosols and aerosol transmission. And one thing that we know about Ebola is that it does cause, especially towards the latter phase, more severe symptoms and more severe phase of the disease, that there's a lot of diarrhea. Hello? All of those things are known to result in aerosols. We also examined the fact that there's some data that suggests that Ebola can remain viable in the air. That's another feature that would suggest it's an organism that can be aerosol transmissible. And finally, we examined the data about how the disease is actually progresses once infection occurs. And it was clear that Ebola is able to take advantage of several different kinds of cells, including dendritic cells and macrophages. These are cells that are located in all epithelial tissues, including the respiratory system, and it's very effective at taking over these cells and using them to replicate itself and transmit itself throughout the body. So even though it doesn't necessarily cause a respiratory disease, it was pretty clear that there are receptors in the respiratory system for Ebola. All of those things were reasons that they added together for me into a strong suggestion that one should be concerned with aerosols in addition to direct contact with body fluids. And when one comes to the conclusion that aerosols are important, then it's clear that one needs to be wearing respirators and not surgical masks. And I don't plan to talk at all today about surgical masks versus respirators, but I will refer you to papers that I've written and research I've done and a blog on the NIOSH website that discusses the differences between the two and respirators are the only form of personal protective equipment that will prevent inhalation of aerosols. Surgical masks will not. So I also then conducted a qualitative risk assessment using a control banding approach that's been developed by the Canadian Respiratory Protection Group, and it's listed in an appendix in their most recent respirator standard. And that's actually based on some research and in a publication that I wrote a number of years ago. And using that qualitative risk assessment approach, we concluded that it would be the most appropriate respirator for dealing with an Ebola patient, especially toward the latter phases of symptoms, is a powered air purifying respirator or something with greater protection even than that. That would be a minimal level. And the reason I wrote my commentary was that I was very concerned about the numbers of healthcare workers who were being infected and dying in East Africa. When you begin to see deaths in healthcare workers, and SARS is a good example of this, one is immediately concerned that there must be something different happening in the healthcare setting than elsewhere, and that there's more exposure or higher levels of exposure to an aerosol. In the case of SARS, this was the case. This occurred because there was a number of aerosol-generating procedures used to treat SARS patients, and they were creating lots of aerosols and not wearing respirators. In the case of Ebola patients, all I can conclude is that there's exposure to a lot of aerosols during these body fluid emissions, as I discussed. I was also Lisa? Yes? Oh.
Hello. Just speak very, very briefly on the precautionary principle.
Right. So I will. A powered air purifying respirator offers a lot of good options because it has a higher level of protection, but it also offers cooling. And every time one takes one's personal protective equipment off or on or puts it on is an opportunity for exposure, especially taking it off if it's contaminated. And I was reading that in Africa they were taking off their PPE every 40 minutes because they were so overcome with heat and physiologic stress due to wearing the personal protective equipment. So I've been asked to talk about using the precautionary approach. I certainly think the precautionary approach in the case of the United States would argue that we should be also using the highest level of protection we think we can offer and that people can work with in a controlled, negative pressure controlled environment. And clearly something like a powered air purifying respirator or similar would offer better protection than an N95 filtering face piece respirator, and certainly a lot better than what is currently being recommended by WHO and CDC. So the final thing I want to say is that when the first Ebola patient was identified in Dallas, I was asked by various news organizations if hospitals were prepared to handle this patient or a patient showing up at the doorstep of any hospital. And I said I thought that I was sure hospitals must have been preparing for Ebola and they would be ready, since they've had to do similar planning for tuberculosis and pandemic influenza and SARS and other organisms over the last 10 to 15 years. So I have to say I was shocked and sad and very angry about the infection of 2 healthcare workers so far in Dallas. And I have to say I don't understand what happened, except I think that probably the most important reason for this failure in preparation and in proper risk assessment can be pointed directly to the doorstep of CDC. CDC has failed to consult with the federal agencies that focus on worker health and safety, and by those I mean specifically NIOSH and OSHA. If those agencies and occupational health and safety professionals in general, like me and others like me, had been involved in their preparation, worker safety would have been at the forefront of planning, and the precautionary approach would have been a feature of our decision making because the modes of transmission are uncertain and there are few treatments and no cures for this disease. I can't guarantee you we would have said that you need to use a powered air purifying respirator or similar in every situation. I'm not sure that's really the case, but certainly in caring for Ebola patients, in the most significant features of the disease, one should be using at least a powered air purifying respirator, if not something better, and one should be wearing fully impermeable personal protective equipment and have the training that's necessary to don and doff this equipment. Thank you.
You've answered a lot of the questions that the nurses who've been writing to us have. In fact, that was probably the most significant question of all questions on the form that nurses could fill out.
Absolutely. So we have one more presenter, Deborah Gold, who's Deputy Chief of Health and Engineering Services on Healthcare Worker Safety. Deb, are you on?
Yes, I am. I really want to thank you for including us in this phone call and mostly for the opportunity to listen to everybody here and to hear about your good work on this issue. I'm just going to talk briefly about Cal OSHA's role with Ebola right now. We're the agency in California that's within the Department of Industrial Relations that has the mission of protecting the health and safety of employees at work. While isolation precautions for patients may protect the general public, healthcare workers must enter into the environment of infected patients, and therefore we must ensure that healthcare workers are effectively protected. We are working with the other state agencies under the leadership of the Governor Brown to make sure that healthcare workers do get effective protection. California has two major regulations that apply to Ebola. The first is bloodborne pathogens, which is similar to federal OSHA and requires that employers train employees, utilize universal precautions, which in healthcare are called standard precautions, engineering controls, and personal protective equipment to protect employees against contact with blood and other potentially infectious materials. Personal protective equipment must be sufficient to prevent the bodily fluids from reaching the employee's clothing or body. And this standard also requires effective disinfection of the worksite and appropriate cleaning or disposal of PPE, which means effective decontamination procedures for workers. The second regulation, which is the Aerosol Transmissible Diseases Regulation, is a California-only standard that was adopted in 2009 with the active participation of the California Nurses Association in the rulemaking process. Ebola is covered by this standard, and according to CDC guidelines, the Ebola virus may be spread by droplets, and the CDC recommends droplet precautions for Ebola. The CDC has also recommended aerosol protections, such as respirators and airborne infection isolation, if aerosol-generating procedures are done. The ATD standard made the CDC and CDPH recommendations enforceable by Cal OSHA for the protection of employees. This standard requires that employees follow the CDC guidelines for droplet and contact precautions and to follow any additional precautions recommended by the CDPH or the local health departments. Cal OSHA regulations also apply to personal protective equipment. Employees exposed to Ebola suspected or confirmed cases should be using fluid-resistant PPE, which may, if there's not a lot of generation of fluids, include fluid-resistant gowns or impermeable or fluid-resistant coveralls, head coverings, eye and face protection such as a face shield, gloves, and any other covering necessary to protect the employee's clothing and skin. In addition, respirators are required to be used for any procedure that may generate aerosols. The term respirator, as Dr. Rousseau said, refers to a device that's been approved by the National Institute for Occupational Safety and Health that will effectively reduce the concentration of aerosols that employees will breathe in. The California ATD standard is aimed at preventing worker illness from infectious diseases that can be transmitted by aerosols that contain viruses, including Ebola, bacteria, or other disease-causing organisms. While the ATD standard is only mandatory For certain healthcare employers in California, it may provide useful guidance for protecting other workers exposed to Ebola virus. Cal OSHA regulations also require that the employer have effective decontamination procedures, which include formal procedures for the doffing, which is the name for removing, and disposing of or cleaning personal protective equipment. Employees must be trained in these procedures and should practice them in dry runs until everybody is comfortable with those procedures. Employees who are also using PPE should assist other employees in donning and particularly in taking off their PPE, and supervisors have to be instructed to oversee the use of PPE. California will work with the Department of Public Health and local health departments, hospitals and other employers, and employees and their unions to ensure that employees have the necessary protections so that they can do their jobs without fear of exposing themselves and their households. I've only briefly summarized the ATD standard, and there's a lot more in there that we hope will be protecting employees in this against this disease. Thank you.
Thank you, Deb. And you can be sure that we will be, you'll be hearing from us because, and I'm glad that you have been on the call because we are quite alarmed with regards to our employers not complying with those standards.
We'll be asking our governor in California to actually help us with our executive order with the President of the United States as well. Okay, now I want to actually change up the agenda a little bit because I know the press has been very patient. This conference call was actually for the nurses. Since we have 11,500 nurses on the call, we wanted to provide as many of the answers as we possibly could. But now I'm going to go to the press questions, and then we'll come back to the nurses again, time permitting. So do we have the press lines open? All right. So we have a question from the press.
Press lines are open at this time.
Okay. Can you identify yourself, please? I know they've been waiting anxiously, and there's a lot of press on this phone. It's a difficult. I think we've got, like I said, we have 4 lines coming in.
Question here.
Oh, sure. You want to identify yourself?
I'm George Osterkamp. I'm with CBS News. How do you come up with the number 11,500 nurses on the line?
We had, we did this 3 ways. We had a Facebook sign up, then we had a website sign up, and then we had another, I don't know what, email sign up. And so on the Facebook, we had, well, this is a little while back, so I've got old notes on it. But anyway, the majority of the people, of the nurses, signed up on Facebook, and then the others on our web and email. So that's how. People had to sign up to be on the call.
I have a question.
Yes.
I'm Rob Arnigo with KGO Radio.
KGO Radio?
I noticed the sign says, don't blame nurses, veterans, stop blaming nurses, but that's one thing that you didn't mention. Why do you feel that the nurses are being blamed for what's going on?
What happened initially in Dallas was on Sunday when the story broke. The nurses, the first reports out were that the nurse did not follow protocol. What our nurses did were immediately to go in front of Kaiser Permanente, put up a picket. Oh, well, that wasn't a picket line. I want to be very clear about that. It was a press conference. Press conference to say that don't blame the nurse. That our folks, we have heard consistently across the country that there are no protocols in place. To blame a nurse from Dallas, we didn't have to talk to the nurses from Dallas. We knew there were no protocols in place if it was the experience of every other hospital across this country. When we finally made contact with the nurses yesterday in Dallas when they called us, and they called us because the nurses did do that press conference saying don't blame the nurse. They felt like nurses across the United States were supporting them, cared about them, and it touched their hearts. They called us, and they were brave enough to speak out. And we subsequently have our hospitals and the CDC and whoever was saying, well, the nurse didn't follow protocol, to backtrack from that, because what we found was there were no protocols in place for the nurse to follow. Yes?
Bay Area. We've heard a lot from nurses from across the country, but in your estimation, do you have an idea of how prepared or not prepared Bay Area hospitals are? I mean, and have you been talking to the hospitals?
Yes. Okay, well, we have nurses from across the Bay Area actually in this room. So how many nurses in the Bay Area feel like your hospitals are prepared? Raise your hand. That was a question. How many of you feel that the hospitals in your area, let's do it in the adverse. How many feel that their hospitals are not prepared? Okay, so that's kind of just a random sample. Nurses are not. We are in negotiations with a lot of hospitals in the state of California, and I can tell you, and the hospitals can tell you, that they're not prepared. They initially, the thing is, what happened initially was they tried to have this facade of preparedness, and it was completely insulting to the nurses. They were telling the nurses who were asking what are the protocols, particularly when the first case was in Kaiser Sacramento, potentially, that didn't occur, that the hospitals are acting prepared. They weren't, and we found that out. I mean, Deborah Arzini can talk about what happened there, but we knew immediately. The nurses were saying the hospitals are telling them when they want to know what to do to look at the CDC guidelines. It's supposed to be virtual education instead of hands-on, continuous, integrated training. They were saying to the nurses, go look it up on the website. That's outrageous. So there's inadequate equipment. There's no education and training. There are no protocols in place. I can't name a hospital in California. We're in touch with the nurses in California, throughout California, and we find it outrageous. The California hospitals I can speak directly to are in bargaining if the hospitals don't come. But we're asking the President of the United States, and we're serious about this. This shouldn't be on us having to picket individual hospitals across this country or in the state of California or make these demands and fight through the press. This should be the mandate in this country. This should not be. The onus should be on the nurses to go and provide the best and highest level of patient care that they can provide in their loving, kind, humanistic manner. They shouldn't have to be policy wonks in terms of figuring out how to get the resources that they need to care for their patients. And that's what they're hearing in California. That's what you just heard in Massachusetts. That's what you're hearing in New York. That's what you're hearing in Florida, Texas, Minnesota, Minneapolis, everywhere, Illinois. I mean, everywhere across this country. And it's being echoed around the world by the nurses who are on this call from around the world. This is an outrageous moment that we're in from a total lack of public policy and austerity measures that have undermined the care of people across this world. We have a problem with the press on the queue. We can't get them. We apologize. I know they'll be calling our communications department nonstop, and they'll be mad at us. But anyway, the nurses will be available to the press to talk to the press, and the experts will be available to talk to the press. If there's anything that anyone here feels unanswered that perhaps we can be responsive to while we have a few minutes, or if there's anyone of the nurses who spoke who have a further question, we can go to that. But we want to go at this point in time back to the University of Chicago nurse, and then we're going to be talking about what our toolkit looks like in terms of what we can do. So back to Illinois. Talisa Harden, are you on the phone?
Oh. Hello?
Yes.
I'm sorry, when you said an Illinois nurse, I'm sorry, but I'm an industrial hygienist, so I didn't immediately make a connection. So do you have questions?
Oh, no, Lisa, no, I'm sorry, wrong. No, I was talking about Talisa. Okay, let's skip this part, and let's see. Okay. Well, we just found out that New York Presbyterian agreed to the nurses' demand for preparedness during this call, so that's it. They agreed to 3 nurses to 1 Ebola patient. Okay. Okay, so let's go to what are the next steps. Oh, I'm sorry.
Suzanne, Talisa is on the call.
Oh, Talisa? What do you want? Okay, Talisa? Okay, never mind. All right, so right, so I just want to remind everyone that we have an Ebola preparedness hotline. We're encouraging nurses across the country and across the world to blow the whistle on their employers. Call us, and we will protect your confidentiality as much as we can at 1-888-381-4585. For unionized nurses, you blow the whistle all the time because you've got those protections. For other nurses, call us. We'll work with you. We are getting a lot of calls, I have to say. What do? I don't want to go to work. I don't want to go to work. We're getting a number of those calls. That's not the responsibility of the nurse. The nurse has to provide for her family. That's the responsibility of our government in this country, right? And this is a bipartisan issue, so this is not about the CDC, and I know everyone wants to blame the CDC, and actually, I think a lot of nurses are very mad at the CDC, but this goes far beyond the CDC. This is our policymakers who've underfunded public health in this country. This is a bipartisan lack of funding. This is a lack of political will, and now those roosters are coming home to roost because we have a crisis in this country and across the world, and no one is impervious to that. Even the rich people who fight against a public health system could be exposed. All right. All right, so now I'm going to go to Michael Leidy here, who's our Public Policy Director, to talk about what our next steps and what to do next.
All right, thank you, Roseanne. We have the toolkit that Roseanne referred to is available on our website, nationalnursesunited.org. That includes the letter to President Obama that nurses from around the country will be sending to him. So if you want to get a copy of that letter, pass it on to the President, there it is. Also, the proposed bargaining demands that we are making to hospitals also around the country are in that toolkit. You can use that in your hospital, and that is a guide for the kind of response we expect every hospital to make. There's also a nursing practice update on personal protective equipment within the toolkit that you can refer to, as well as whistleblower laws. We certainly don't want to have happen to any other nurse in the country what happened to the nurse in Florida when she tried to get information. So there's also an opportunity to review those laws. We encourage you to send your story of hospital preparedness to Ebola Protection at nationalnursesunited.org. Ebola Protection at nationalnursesunited.org. Also, visit the rn.org website. You heard from a couple of nurses who participated in RN disaster relief program. That's where you can assist efforts in West Africa, is through the rn.org website. And of course, the nationalnursesunited.org website has other tools you can use to contact members of Congress, not just the President. Pass on our concerns and demand for executive action on to your member of Congress. Pass it on to your United States Senator. Governor Brown and other governors around the country need to hear from registered nurses to demand the optimal level and the highest standard of care and protection for yourselves and also for your patients. All these tools are available to you, nationalnursesunited.org, and also the hotline that Roseanne mentioned, again, 888-381-4585. It's imperative that we hear from nurses and we're able to address those concerns and get those concerns not only to the hospital administration, but to decision makers around this country to ensure the safety of you and your patients.
Thank you, Michael. So I want to make three final concluding points. One is that on the issue of hazmat suits, the gold standard of hazmat suits would be worn by hospital administrators if they had to take care of patients. You can trust that. And they would. I mean, they would absolutely. They would have been in place. They would have been in place in March when the CDC suggested there might be a problem. The other is on the CDC. They're saying, well, are nurses capable of being trained to wear hazmat suits? And I noticed when the CDC's transporting Ebola patients, they all have hazmat suits on. If it's good enough for the CDC, even if it isn't good enough for the CDC, our nurses want the optimal protection, period. And we're not going to stop until it's done. You know, if we it shouldn't be a war to protect our nurses across the world. I mean, it was the scariest thing that I heard on this call is what did they call Deborah? The killer. The nurse killer, that's what they call it in nurse killer disease. The nurse killer disease. My God. My God, I think that sent a chill to everybody that's on this call. So, we are not going away. The National Nurses United is not going away. We're not going to be delegitimized. We're not going to be silenced. And we're going to fight all the way down the line for every nurse in this country and across the world to have the optimal standards to take care of their patients. Nothing short of that is acceptable. And I'm telling you, I know our leadership, and they're not going to back down. So we're with you. I know people are very fearful at this point in time, but the best way to confront that fear is through preparation, and we all know that, to be ready. Be ready to take care of your patients. So we got one last point here from Michael Eddy.
Yeah, that's the correct email address, sorry. Ebola prevention at nationalnursesunited.org. Ebola prevention at nationalnursesunited.org. We want to hear your stories about the inadequacy of hospital preparation.
The way to stop Ebola is to be prepared. It's for containment, and the ones who are on the front line are the ones to do that. You shouldn't be in this position. We apologize for the fact that you're in this position, but you have you might not have all the policymakers in this country with you, but I can tell you this, you've got the people of the world with you. The public trusts the nurses. Number one, in credibility. The public trusts you, the public's with you. And so when people say, well, you've got all these groups that are agreeing with, the CDC or the lack of standards, who's on your side? And we say, oh, that one small group is called the public. Thank you. What a time. Oh. Yeah. It's outrageous, right?